Good afternoon. I welcome you all to this session on pterygium management. We all know that pterygium surgery has been performed for more than 3,000 years, and that is from the days of Sushruta. We have various surgical procedures that are available now, but we are not sure which procedure works best for a particular type of pterygium. And recurrence of pterygium after its surgery is one of the frustrating cause of concern for both the surgeon as well as for the patient. So we have set of topics and going to most of them are video based presentations and going to give practical tips to how to reduce recurrence in pterygium management. So, with this brief background, I would like to invite the first speaker, Dr. Vamshi Konuganti. He is center head of the Eye Foundation, Metupalayam, and he is a senior consultant, cataract and external diseases at Metupalayam, Tamil Nadu. It's going to talk about medical management of pterygium, what is new. Over to you, Dr. Vamshi.
At the outset, good afternoon, everyone. Good afternoon, everyone. I'd like to thank the AIOS Scientific Committee to give approval for this instruction course, and would like to thank the chairman of the AI Foundation, Dr. D. Ramurthy, and Dr. Shirish Kumar sir, to include me in this instruction course. And friends, as we all know, pterygium is a fibrovascular degeneration lesion of the conjunctiva that occurs only in humans. Clinically, it presents as a triangular-shaped conjunctival hyperplasia with its apex directed towards the cornea. The most common location of pterygium is interpapillary fissure and papillary conjunctiva on the nasal side. And it impairs vision. And according to Sharik et al., wherein a meta-analysis was done, what happened was the actual incidence of pterygium is around 12% in 2018, and meta-analysis following that, they've denoted that around 1 to 30% of the population gets affected by this pterygium. So I'll be speaking regarding the medical management of pterygium and what's new. The topics are I'll be talking regarding the medical adjuvant therapies, a comparison of these options, and is there any role in primary and secondary pterygium, and medical therapy replacing surgical options. Yes, we have some new drugs which are coming out, which they claim that it replaces surgery. So coming to this citation and the techniques, the primary surgical technique for pterygium management and the recurrences, what happens is these are the different types of techniques which are used for pterygium. And we at Eye Foundation have done a 15-year study by Kodover et al., which is published in 2024. Compared to the normal studies which been quoted, the incidence of recurrence of pterygium is around 0.3% compared to the 1.3 to 14.4% of the conjunctival autograft, which seems to be the best technique for avoiding recurrence of pterygium. And compared to the other techniques also, we did the 15-year study ruled out that we have better outcomes, but anyhow, recurrence is a problem. And the mechanism of pterygium is quite complicated, and they say that angiogenesis and vascular proliferation are the key factor in the pathogenesis of pterygium. And as we all know, vascular endogenous growth factor, VGFR2, and different mechanisms are denoted to note that the pterygium causes pterygium actually. So targeting these methods, and the new drugs are coming to target these methods so that we don't get that proliferation of pterygium. And the medical the medical management is only an adjuvant therapy as for it now. So these adjuvant therapies are we have anti-neoplastic agents like mitomycin C and 5-fluorouracil, anti-VEGF, that is bevacizumab and ranibizumab, and cyclosporine eye drops. Mitomycin C, as we all know, it's an antineoplastic agent, and it's an alkylating agent that inhibits the DNA replication, leading to cellular death. And it can be used both post-operative pterygium surgery with varying degrees of success. And primary pterygium, the recurrence rate is around 4, and recurrent pterygium is around 4 to 39%. In our hands, it comes to around 3%. And the dosage is around 0.01% to 0.202 and 0.04%. Regarding the different options of mitomycin, all the studies have ruled that it can't replace the congenital autograft what we do. So the congenital autograft is the primary treatment for a primary pterygium actually. So so what's the role of mitomycin? Mitomycin plays very good role in case of high-risk pterygiums, young patients with high chances of recurrence. So in those patients, when we combine the congenital autograft with mitomycin, it has better results. The safest option is around 0.02% for 3 minutes. The dreaded complication of this is scleral thinning and necrosis, but for this dosage, not much of studies have revealed that the side effects occur. And coming to 5-fluorouracil, it's a pyrimidine analog in which DNA synthesis blocking proliferation of imprinted cells such as fibroblasts and decreasing the healing response. It can be used as eye drops, but they have the complication of epithelial keratopathy, which occurs in 10%, and there is a 10% recurrence. And the interlesion injections are much better, and it halts progression, but the biggest complication is granuloma formation and vascularization, and can be given the dosage of 0.1 ml in a 5FU and 5 mg in 1 ml syringe, given intralesional. This is usually given post-op for preventing the recurrence of this one. So this is the chart which depicts the use of efficacy of 5-fluorouracil. But whatever it is, again we come back to the same this one. Congenital autograft has the primary good response compared to all the adjuvant therapies. Coming to the next, this one, anti-VEGF agents, that's bevacizumab and ranibizumab. These are recombinant monoclonal antibodies capable of binding to VEGF to neutralize its actions and reduce fibrovascular proliferation, vascularization. They can be used as injections or drops, and ranibizumab can be given as injection. This subconjunctival before and after surgery. The safety profile is it's well tolerated. And if we compare the different techniques, again we come back to the same this one, wherein congenital autograft has a better this one compared to the adjuvant therapy. But it can be used in case of recurrent this one. But the only thing is the cost factor. Especially in India, the cost factor is the most important this one. And most of the pterygium affected patients are, the economic, this one, they belong to the economic category wherein the cost matters. So primary pterygium doesn't have much benefits, but recurrent pterygium for reduced vascularity for 3 monthly doses can be given. And cyclophosphorin 8 drops, these are immunosuppressant agent that acts on T cells, thereby inhibiting interleukins, which reduces the intensity of inflammatory response. It has mixed results. The efficacy and safety profile has a mixed result. And meta-analysis it says that significantly reduces regression, and it can be used in dosage of 0.05% and 0.1%. So when we compare both all the medical adjuvants, as we see, the congenital autograft has the lowest recurrence rate compared to other treatment options. And the mechanism of mitomycin C and amniotic membrane and anti-VEGF agents and fibrocell, if we see, the lowest recurrence rate is in congenital autograft. In our hands, in Eye Foundation, led by Kadur et al., the percentage is quite significantly reduced compared to the international studies. Coming to the emerging pharmacotherapeutics, that is curcumin, RHO kinase inhibitors, nintedanib, and role of lipid metabolism in pterygium. They say that the statins, what we take for high lipoproteins, they also have a role in reducing the pterygium. So whoever is consuming statins without knowing the benefits, we have been protected with from the pterygium. So, Rho kinase inhibitors is the one wherein it inhibits fibrosis and cell this one, and it's a novel post-surgical treatment. Nintedanib has this one wherein it has a promising target therapy for pterygium cells. So this is the new kid on the block. They say that it's a multi-target tyrosine kinase inhibitor ophthalmic solution which is available in drops, and its aim is that it's a new non-surgical alternative. It has undergone 2 trials, and now it is in the phase 3 study done by Cloudbreak Pharma based in Irving. And it says that it acts on 3 mechanisms of pterygium. The causative factors of all the 3 cycles it takes care and effectively reduces pterygium size and symptoms in patients with primary recurrent cases, as denoted by Whitcup et al. In 2024 paper. So efficacy is in reducing vascularity, lesion size reduction, and safety profile. It has a potential as a disease-modifying therapy, and it has regulated process. So I think, friends, as we all know, right now the medical treatment is only an adjuvant, this one, to prevent the recurrence. But we have newer therapies which are emerging, which they claim that it reduces the incidence of need for surgeries. Thank you.
Thank you, Dr. Vamshi. One question to you, most of the medicines what you have mentioned are either given before surgery or during surgery or after the surgery. Do they replace surgery?
No, that's what, sir. As the talk rightly predicted, nothing to replace the congenital autographic as we speak right now.
And you mentioned about that CBT, which is under trial, that tyrosine kinase inhibitor.
Yes.
So, what is the kind of role it has? Is it like it is just chemo reduction? Is it going to reduce the vascularity and size of the pterygium? And
Exactly, as you pointed out, it reduces vascularity, and then what they say is the pterygium has a homeostatic effect on this one, wherein the fibroblasts and myofibroblasts, they proliferate and they cause the pterygium. So they claim that the CBT-100 acts in 3 ways. It all blocks all the 3 pathways, leading to this one, all the factors which are relating to pterygium occurrence. So they say that it's like nip it in the bud, so we can make patients free of pterygium.
At present, the role of mitomycin C in pterygium is it's like it can be used preoperatively, intraoperatively, or postoperatively, and it is actually practiced for recurrent pterygium. And there's various protocols that has been followed. So preoperatively you can use it as eye drops 0.02%. 0.02% is as effective as 0.04%. So we can use a lower dosage, lower concentration, so that you can reduce all the complications, and it's been proved that 0.02 is as effective as 0.04%. Exactly. And it can be even used intraoperatively or postoperatively. Postoperatively, we prepare drops and give in patients with progressive kind of pterygium, or those who have had a recurrent pterygium. It can be given. So other than that, right now it doesn't have any role, and to reduce the congestion or the symptomatic relief, we can use these medicines.
Yes, sir. Exactly.
So now we'll move on to the next topic, cataract with pterygium, simultaneous or sequential. So we have with us Dr. Rajesh Sinha. He is professor cornea, cataract and refractive surgery at RP Center, and he is the secretary of Indian Society of Keratorefractive Surgeons, ISCRS. So very dynamic surgeon. So over to you, Dr. Rajesh.
Thank you, Dr. Suresh, for having me in this very interesting and useful course, because we all encounter such scenarios. We all get to see patients. We are living in a tropical country wherein the number of pterygium is quite high, and the cataract also is reasonably high. And so we do encounter conditions wherein we do have cataract with pterygium. So what should be the approach? It can be either simultaneous, you do pterygium surgery along with cataract surgery, or you can do a sequential surgery, do a pterygium first and do a cataract surgery later. So whenever you decide about 2 things, there are always pros and cons of each protocol. So if you do a simultaneous surgery, the advantage is that the patient comes to you once, gets rid of everything, goes back happy, satisfied, and the visual rehabilitation is done. However, if the pterygium is thick, fleshy, and it is causing some degree of astigmatism, there may be some IOL power abnormality, IOL power error in that. And that is one issue. Apart from that, many times when you do surgeries, we cataract surgeons, we like to do a topical phaco absolutely white eye, and when you do a pterygium along with cataract and later on the patient comes with red eye and all that, we don't feel very happy about it. So that's one thing. Patient also says that it has been done, I can see clearly, but there's a lot of redness. So that we have to explain, and he may say that I have undergone a cataract surgery, but there's so much of redness. So these things are there. However, well, sequential surgery has the advantage of all these, that you can have a accurate biometry, and first you do a pterygium surgery, explain to the patient that this is a surface surgery, there can be a little bit of redness and all that, and later on you will do a cataract surgery wherein the IOL power will be absolutely accurate. But then it's a two-stage surgery, so that's one disadvantage. So we have to keep thinking about what to do. I mean, there should be a scientific way instead of a social way of thinking that the patient has to come twice, or the patient will feel that it is red and all that. So let's think about how to decide. Now, if we think about, when do we think about sequential procedure? When it's a large pterygium involving more than 2 millimeters of cornea. It's a double-headed pterygium, and all these can result in significant astigmatism and topographic distortion also, wherein you will not get an accurate biometry. In such a case, it is advisable technically, scientifically, that we should do a sequential surgery, do a pterygium surgery first, and then later on, once the ocular surface and the biometry stabilizes, we can go for a cataract surgery and with an accurate IOL power. So wait for a couple of months, 6 weeks, for everything to stabilize, and then go ahead. When do you think about simultaneous surgery? When it's a small pterygium, not causing significant degree of astigmatism. The Myers are regular, the patient cannot come for follow-up. Patient says that whatever you want to do, just do it once, and I cannot come for follow-up. So these are some of the issues wherein you can think of simultaneous surgery. But scientifically, if it is involving less than 2 millimeter of cornea, then it is not usually visually significant, but that can only be ascertained by doing a topography when you see that there is no significant astigmatism. And some cases wherein you have a very thin and atrophic pterygium, long-standing, not causing any astigmatism, you can just go ahead and do a cataract surgery and the patient will be happy. You will have a good biometry and the IOL power calculation will be good. Something like this, encroaching onto the cornea this much, you have to do a sequential surgery. Something which is up to less than 2 millimeters, you can go ahead with a simultaneous surgery. I'm sorry. So somebody having a pterygium with cataract, with involving up to say 1.5 millimeters, not having significant astigmatism, in such a case we can go ahead and do a cataract surgery along with pterygium surgery. So once we do a routine cataract surgery by chopping, I'll just move on and put an IOL, and once you have put an intraocular lens, then you remove the viscoelastic, then hydrate the wound. You can put air because that will maintain the chamber, because there is some manipulation required, and then very gently you dislodge the head, and then once you have dislodged the head of the pterygium, you can cut it at its neck. I'm sorry. You can cut it at the neck, and then after that, you can just smoothen it using the back surface of crescent blade. You can use a diamond burr to smoothen it. You can get a conjunctival flap from the other side, and this graft is brought into position, and then you put fibrin glue and then place it. Some people use autologous blood as well to adhere the conjunctival graft, and once it is in position, it acts as a barrier. Basically what happens that it is a fact now that pterygium is considered as a condition wherein there is some localized stem cell deficiency by which these this fibrous element, they cross over the limbus and covers up the cornea. Now, there is a reasonable predictability if the of the IOL power if the pterygium is not significantly thick. But if it is thick, then it will, what will it cause? It will, normally pterygium causes a flattening of that axis. So if it's a thick fleshy pterygium, when you remove it, then that axis will become steep, and it also increases the spherical power. It causes some degree of steepening, and that is why if you do a simultaneous procedure, then some patients might have a small degree of myopic shift after the procedure if you are doing a combined procedure. If you have something like double-headed pterygium, although pterygium here is encroaching up to say about 3 millimeters of the cornea, here it is encroaching only up to 1.5 millimeters, but still, since it's a double-headed pterygium, we would like to do a sequential procedure. So first we will remove this pterygium and then dissect at the neck and remove this. And it's always better, what this is my preference and the preference of many people, that I would also like to dissect the subconjunctival fibrotic tissue and remove that, so that when we stick the conjunctiva, there's no remaining subconjunctival degenerative, this is a elastotic degeneration, subepithelial degeneration. So that tissue has to be removed. And then of course, the other side also is cut and removed, and then we create a similar kind of a autoconch, and then it is what you do is that you put it in a reverse manner, just adjacent. I'll just finish it in a minute. In a reverse manner, put fibrin glue and then you reverse it. So that is how you can stick it, and that's the end of it. You can use diamond burr to smoothen the surface. And this is one study which has shown that pterygium extending more than 2 millimeters into the cornea can have a significant effect in the error in the intraocular lens power calculation. And as I said, it causes myopic shift if you do a combined surgery in a fleshy pterygium, particularly encroaching up to 2 millimeters up to the cornea. And lastly but not the least, when a patient with cataract and pterygium comes to you, it's very essential to counsel the patient, explain to him why a patient who has come to you with a diminution of vision and somebody has told that it's a cataract, why you are doing a sequential procedure. So a good patient counseling is very essential, particularly in such a case wherein you have a pterygium extending up to this area and you are planning a sequential procedure. So if you don't do a proper counseling, the patient will be lost to follow up, and that is something which is a loss to you and also to the patient as well. So thank you very much for your patient listening, and would like to have comments from all of you, because all of you handle such cases.
Thank you, Dr. Rajesh. It's a nice presentation. It's a nice surgical videos you have shown, and it's definitely a dilemma whether to do a combined procedure or it's like simultaneous or separate surgeries for both pterygium and cataract. So, like if the patient is a non-demanding kind of patients, if the pterygium is small, we can go ahead and do a combined procedure. But if the patient is a demanding type of patient, or now this is a era of premium IOL surgeries, do you put them on 2 Barrett's calculator? Like it gives you all the, like even a 0.5 diopters of against the rule astigmatism, it will give a toric power. So we put them on Barrett's calculator. If the astigmatism is against the rule, even if it is 0.5 diopters, it gives you T3 or T4.
Absolutely.
And if it is with the rule, even if it is like 1 diopter, you may not get a toric power. So, like, do you really consider this with the rule astigmatism and against the rule astigmatism while considering a combined procedure?
Actually, if it's a small degree of astigmatism, then only I will do a combined procedure. And in such a case, See, if it's a with the rule astigmatism, then also I will consider. The reason is this, that the pterygium is mostly in the horizontal meridian. And when you remove the pterygium, the with the rule astigmatism will worsen because it will become steeper.
More steeper, yeah.
Yeah, actually, no, I'm sorry. It will become flatter.
More flat.
So in that case, yes, your point is right that if it's a with the rule astigmatism of one diopter, then if it's a fleshy pterygium and you're doing a combined procedure, then you do expect some degree of steepening in the horizontal meridian and then corresponding flattening in the superior meridian. So in that case, yes, we may consider, we may not consider that. But if it's an against the rule astigmatism, then in that case, yes. I mean, any astigmatism which is higher, therein we do have to consider, because it is very difficult to exactly predict that how much of astigmatism will be corrected by
We are
removing
not
the
sure
pterygium.
whether the astigmatism is only because of the pterygium. We have to compare it with the other eye.
Other
If
things
the other
as
eye
well.
also has got
Absolutely.
similar astigmatism,
Yeah.
then it may not be because of
Yeah.
pterygium itself. Yeah.
Yeah, yeah. Yes, in a bi-headed pterygium, again, it will cause more of flattening. So the horizontal meridian will be flattened. So if you remove it, so what happens is that that meridian becomes steeper, and so the astigma, if suppose the patient is having with the rule astigmatism, then the astigmatism will reduce. But if somebody is having against the rule astigmatism, the astigmatism will increase. So these considerations have to be taken, what Dr. Sirish was telling. And it also causes some degree of steepening of the cornea, overall steepening. This study showed that there was a myopic shift of 0.91. So that is a significant in a fleshy pterygium which was encroaching more than 2 millimeters of the cornea. Having said that, this was one set of patients. After handling so many patients, after doing many sequential procedures, I am yet to learn, and I would like to learn from you that I am yet not able to predict how much of astigmatic change will occur with removal of a particular pterygium. It is not 100% predictable. So that is why if it's a fleshy pterygium involving more than 2 millimeters and there is a significant astigmatism, we can do a proper counseling and do a sequential surgery. That is the best thing to do, because many times the astigmatism can, if there is an uncorrected astigmatism, these days toric lenses are very good and they provide very good results. So if there is uncorrected astigmatism, the patient will still have some degree of blurring, little bit of blurring. Even if somebody can see 6/6, but will say that the crispness is not there. So these days when people want absolute crisp vision, I think a good patient counseling chair time is important, and that will help us in getting good patient satisfaction.
Exactly, Dr. Rajesh. I think
Nothing, sir, because we are just removing the conjunctiva, leaving the tenons, and we leave it like that. The conjunctiva grows over it, and it is, we don't breach the limbus. It is beyond the limbus, so it will not cross over the limbus. So it will just cover up there will be epithelial proliferation, and it will cover up that area.
any doubts in this? Yeah, please.
Thanks, Professor, for this nice presentation. What's your preferred manner in case of intumescent cataract and in patient not fit for phacoemulsification, patient with extracapsular cataract surgery? Do you prefer the simultaneous or?
Can you use the mic, please?
Yeah, yeah. See, when you are doing an extracapsular surgery and putting 4 or 5 sutures, then obviously you are ready. I mean, you are not implanting a toric IOL, and you are ready for any astigmatic change for which you have to counsel the patient, and you have to give post-op refractive correction. right? But these days, even with intermittent cataract or whatever type of cataract is there, 99% of, I mean, I won't say 99, but more than 90% people are doing phaco. And they are doing small incision phaco, 2.2 millimeter incision phaco, which is self-sealing and all that. So in such cases, you have to consider that. But if you are doing an ECC, putting 4 or 5 sutures, then it's better to do a simultaneous surgery, because in any case, I mean, there will be astigmatism because of the sutures. So you're not telling the patient, you have to counsel the patient, and you're not telling the patient that you will be astigmatic free.
Okay. Thank you, Dr. Rajesh. Please come. Yeah. Any other question? Yeah, please. So, if it is a small pterygium less than 2 millimeters, if the patient expectation is not high, we can go ahead with the simultaneous surgery. If it is a large pterygium, if it is a deep pterygium, if the pterygium involves deeper layers, usually the deeper layers, the astigmatism induced will be very high. Such cases, it's better we do pterygium first and then go ahead with the cataract surgery later. So we'll move on to the next topic. Dr. Satyamurthy. Dr. Satyamurthy is a senior consultant cataract, cornea and refractive surgery from Joshi Eye Institute, Hubli, and he is presently heading the Joshi Eye Hospital, Dharwad branch. He is an excellent cornea refractive surgeon. He is going to talk us on management options for recurrent pterygium.
Yeah, thank you very much. At the outset, I would like to thank Dr. Shrees Kumar for giving me opportunity in this instruction course. And then a lot has been already told by Dr. Vamshi in the form of studies as to how many cases do recur, and as probably this is one of the complications of the primary pterygium surgery. So now let's see. The problems with the recurrent pterygium are that it is very aggressive, maybe more aggressive than the primary pterygium itself, and sometimes it can go up to the center if patient doesn't come immediately. And then there can be intense fibrovascular proliferation. I do agree that it's not the pterygium which has grown back, it is probably the fibrovascular tissue from the fibrovascular element which grows, and it is sort of excessive healing response from the body. So that's why. And then adhesion to sclera and underlying muscles is very, very important, and this may result in the restriction of the movement of the eye, thereby the restrictive strabismus, which also has to be taken into account. And then the corneal extension resulting in astigmatism. It may be much more than the primary pterygium itself, and surface scarring and significant visual problems in case if the central part of the cornea is involved. And then the factors for recurrence are, one is the incomplete control of the post-op inflammation is one of the significant features. They can, the inflammation may be because of excessive suturing. There are a lot of studies comparing the glue, fibrin glue versus the suturing. Fibrin glue scores over this, and then the incomplete removal of primary pterygium itself. Maybe at one end the pterygium is still not removed from the thing. That then insufficient conjunctival graft size, or if the tenon is also included in the graft, and graft is very thick, probably it may not prevent the recurrence. And then the graft can be lifted because of lifting, because of the edema or a clot, sub-graft clot, and then graft can get retracted. And then younger patients are more prone to developing the recurrence, which we'll see later. Then in case if pterygium is fleshy and highly vascular, the recurrence is definitely higher. And then if patient is associated with Demodex follicularum infestation, or what we call ocular demodicosis, and recurrence rate is again high. And in case if there is mutation of one of these genes, that there's about 8-fold increase in the sequence of recurrence. And then if there is any viruses like HSV or CMV, again recurrence rate is high. In younger age group, the rapid reepithelialization is one of the reasons for and their very aggressive collagen synthesis, and rapid angiogenesis, and vigorous inflammatory response is and increased outdoor activity. Of course, the young people are known for this, and that's why the recurrence rate is a little higher. And then a lot of studies have shown that matrix metalloproteins 1 and 3, and then these biomarkers are much higher. And then, so now let us come to the management. How exactly you can manage? One is the fibroscalar tissue has to be completely removed. Removing of fibroscalar tissue in a case of recurrent pterygium is very difficult because you don't get that plane of cleavage. So, and then it can be firmly adherent to the underlying structures, especially the muscle. So in case if you are not careful about it, then probably it may result in strabismus, permanent strabismus. In fact, I remember a surgeon received a legal notice because patient developed diplopia following surgery for the recurrent pterygium. So always keep this in mind, and then it may be a good, wise thing to hook the muscle before removing the fibroscalar tissue. There can be adequate control of the post-op inflammation, which is one of the reasons why there is recurrence. And then surgical management in case if the conjunctival autograft is, conjunctiva is quite available. So we can include limbal conjunctival autografting, which already has been shown by multiple studies that the recurrence rate is very high. And then we can include mini slit also in this. Yeah, here, so this is the case where after the removal of the pterygium, there was a fibroscalar tissue, and this is a mitomycin C, 0.02% soaked and kept for about 2 to 3 minutes. And then, since the patient had not, the earlier surgery, the conjunctival autografting was not done, so I could take that. And then, so this is exactly what, and fix the graft with the help of fibrin glue, which may be a better alternative than the suturing. And then one can do, in case if patient has got undergone multiple surgeries, one can use amniotic membrane, and then only amniotic membrane may not, the recurrence rate is very high, as we have seen earlier. And then one can do the slit and combine with the conjunctival autografting. The recurrence rate is much so it is just the similar to the slit procedure. So all you have to do is, so this is the pterygium, this is the conjunctival autograft, and then you can place the tissue, fix that with fibrin glue, and then you can put a contact lens. Same thing can be done with the help of with the amniotic membrane, but slit either from the same eye or from the other eye, or AIOS slit probably will help us to reduce the recurrence. At the same time, this mini slit also reduces the scarring, and then cosmetically gives better results. Essentially, technically it is similar. Now the adjuvants, lot has been told by the first speaker about the mitomycin C and then 5-fluorouracil and all these the other adjuvants that are used, and then the newer trends of newer drugs which are available. It has been noted that in case even though the cause-effect relationship is not established, the management of dry eye in these patients reduces recurrence, and then 5-fluorouracil about 2.5 to 5 milligram subconjunctival, you can give. It may require about 10 injections. Maybe it will be a little difficult for the patient to understand that, but in case if mitomycin C is not used, maybe one can use 5-fluorouracil. Mitomycin C 0.0 to 2% is used intraoperatively. Preoperatively, it can also be given about 0.1 ml, 0.15 milligram per ml, which is injected 1 day prior to surgery under the conjunctiva, and then so that acts on the fibroblasts. Fibroblastic proliferation is reduced. Recurrence rate is supposed to be much less, and then intraoperatively, of course, as I showed you here, this is mitomycin C 0.02%, kept for about 2 to 3 minutes, and then washed out. So this is much cheaper as compared to the other modalities, and then it is much effective when combined with the limbal conjunctival autografting and other things probably is. And then you can also tuck the graft. Even though anti-VEGF, the VEGF receptor 2 concentration is very high, so that helps, but I mean the concentration is high, so that led to the usage of anti-VEGFs, but this works only in case in early cases of recurrence where there's early neovascularization and early fibrovascular proliferation. There it will help. And then this is not shown to be very, very effective because multiple injections are required, and the effect is also not going to last for a longer period. Once we stop, then the cost factor also adds. So to this. To conclude, I would like to say that the fibrovascular proliferation has to be completely removed, and then the large tenon-free graft with the proper fixation method, especially the fibrin glue, has to be used, and the post-op inflammation has to be adequately controlled, and then counsel the patient regarding possible recurrence, because the recurrence can, I mean, in spite of all these things, still it can recur. So one has to. Thank you very much for your patient listening.
Thank you, Dr. Satyamurthy, for a wonderful presentation. And pterygia do have a tendency to recur, and many times we have to handle such cases. Many times it becomes very badly fibrosed as well. Sometimes, you know, when you do all these, some granuloma can form if you use sutures. So all sorts of problems can happen when you have done a primary surgery. So these things do happen. And handling recurrent pterygium using the limbal stem cells is very effective, because it is now an established fact that pterygium does happen. It encroaches onto the cornea basically because of the localized limbal stem cell deficiency, and that's why it is more often seen in nasal side, because it's more exposed to the sun rays, and that's why it's more often seen in tropical countries. Very nicely presented. Any question for Dr. Satyamurthy? Yeah, yes, ma'am.
Thank you. Yeah. Somebody?
Satyamurthy, would you advise to give sub-pterygial steroids, say maybe 15 days or a month before surgery in very fibrous vascularized pterygium?
You mean pre-op topical steroids?
No, subtenon or
Subconjunctival?
Under the pterygium.
That's what. No, I mean, it's not.
Does it make any difference?
Not much, unless it is highly inflamed. So, best thing is to control the inflammation with anti-inflammatory drugs. Probably steroid is very
any disadvantage, because that's quite a popular treatment. So, is there
any injection in the eye, patient probably doesn't like it. He resents. So, better to.
There are actually a few studies also, like preoperative injection of steroids or preoperative injection of Avastin has been tried, especially in recurrent pterygium or progressive fleshy pterygium, to reduce the vascularity, and wait for 2 to 3 weeks. Then you take up for surgery. So it will reduce your bleeding during surgery, and cauterization, excess cauterization need not be done.
Correct.
And one more thing is, while using mitomycin C, one should be very careful, like because pterygium per se is not a blinding condition, but complications like scleral melt or corneal melt can happen, because you are going to do cauterization of the sclera, and over that if you place mitomycin C for a few seconds or few minutes, so that can lead to melting, which you have various other procedures like limbal stem cells can be included, and you have already shown SLET with the CAG. So slit with CAG or limbal conjunctival autograft, wherein you can include a thin block of tissue of limbus in the conjunctival autograft itself. That works very well. So instead of using mitomycin C and inviting complications, I think we can go ahead with the conjunctival transplantation itself.
No,
yeah.
correct. I mean, that's used as adjuvant only. It's up to the surgeon. But so mitomycin C has been used by the glaucoma consultants for trabeculectomy for many years, and then doesn't really cause that much problem.
Yeah, I guess mitomycin C is, I guess there's more of a blame to mitomycin C. It's the way it has been used and how long it has been used, because many people use it for recurrent pterygium, many people use it for glaucoma surgery, and we don't get necrosis. But some patients that do come up with necrosis. So what exactly has happened also, that needs to be known. Because in recurrent pterygium, mitomycin C is an established modality. So that is something that can be.
Whenever we are using mitomycin C, after washing the surface, we can even place a graft.
Yes.
Mitomycin C with the cover is very safe.
Correct.
Yeah, graft in
anyway
any
you have
case
to
has to
place.
be
Yeah,
placed.
it has to be
Graft in any case has to be placed.
You can't leave just, I mean, not only mitomycin C as the primary
Best,
treatment, but that can be.
Yes, ma'am.
adjuvant.
Sir, is there any role of a bandage contact lens to fix the autograft instead of fibrin glue?
Yeah, I mean, not really required. The one company which has come with large sized.
Ma'am, the only problem with bandage contact lens is this, that when you blink, it moves. And when it moves, if you haven't used anything to stick the graft, either it is a blood, autologous blood or fibrin glue, then what will happen, even if you use a large diameter one, it will still move and then it will slightly dislodge it. So you need something, maybe the patient's own blood for temporary, sticking of this thing, and then you can use a large diameter. You have to ask for it, because these days bandage contact lens normally are not available of say 17-18 millimeters. They are of small size, 12 millimeters and 14 millimeters, not more than that. So then in that case, it will partly cover the pterygium and it will dislodge the graft. Partly cover the graft and it will dislodge it. That's the problem.
No, one thing, I mean, she's probably talking about this because the one company is projecting, marketing it as a Pterygo contact lens.
I know.
Okay.
Like
What's the size of that? I am not aware.
16 millimeters.
16
or
millimeters.
8,
16
something.
millimeters. But I still feel that it moves with each blink. So unless you put it,
it can dislodge the graft.
it can dislodge the graft unless you put something. Maybe autologous blood you can use, because the blood in any case will ooze once you cut the pterygium. So that should be used at least to fix it temporarily, and then that can be used.
Thank you, sir.
Thank you.
Ma'am?
Are they advocating to reduce the symptoms, probably?
Maybe
Till the corneal scraping, the cornea gets epithelialized, probably patient will have symptoms. So maybe yes. You're right. So,
yeah, I think it's partly covered by the first speaker. Cyclosporin A is like it's been tried actually. Even without surgery also we can use cyclosporin to reduce the symptoms and reduce the inflammation. Topical spike cyclosporin has been tried, and in case of recurrent pterygium or those with inflamed pterygium, it can be tried to reduce the inflammation. Instead of using steroids, post-operatively also we can try. Even it has been tried pre-operatively to reduce the inflammation.
Only thing is that I guess we will have to use a higher concentration of cyclosporin to reduce inflammation.
yeah.
The ones that are available commercially are just meant to take care of a very subtle inflammation associated with dry eye, and not with severe inflammation that we see in these cases. Yeah. So in view of no, Shreyas is here. Okay. So we will have a specific topic, double-headed pterygium. There were a couple of questions, and Dr. Shreyas Ramamurthy will be presenting how do I cover the bare sclera.
Dr. Shreyas is a senior consultant and is a vice chairman of Y Foundation Group of Hospitals.
Thank you so much, sir, for the opportunity. And today I'll just be covering a little bit about double pterygium and the slightly increased challenges associated with double pterygium. So really, it's not very different from a normal pterygium, apart from the fact that you have to cover two sides and you need a little more tissue to cover on both sides. So how do we go about harvesting it, and what could be some steps that we can take is really what I'm going to cover. So really the goal of the surgery is to prevent recurrence. And the reason I'm saying that is, when we say recurrence, we are actually talking about a fibrovascular growth back onto the cornea. We are not really looking at replacing the entire pterygium with a graft, because that is really a challenge when it comes to a double pterygium, because you probably don't have sufficient conjunctival tissue, at least from the superior surface, available to probably cover both sides. So you want to dissect enough tissue that you leave behind a barrier and create a barrier from it, from the fibrovascular healing response to push the graft aside and go on to the cornea. So really minimum complications while achieving cosmesis. Bare sclera, we all know, has a high recurrence rate, so we want to have a tissue graft plus or minus antifibrotics. Generally, for a primary pterygium, whether it is single or double, we don't resort to antifibrotics. Possibly only in a recurrent pterygium, the antifibrotics seem to have a greater role. Now, what are the different approaches? We can either have a conjunctival autograft from both superior and inferior conjunctiva and cover both sides. The reason we generally tend to avoid that is because you're really causing a lot of ocular surface change, because the goblet cells, the mucal cells from the conjunctival surface, the conjunctival epithelium is getting disturbed almost 360-degree, because you're removing conjunctiva on these sides and from both superior and inferior. So to the extent possible, you want to leave at least one surface behind intact, so that the tear film dynamics don't get altered as much. So that's where the split conjunctival autograft comes into place. And we have a vertical and horizontal split, and I'll just show a couple of videos on that. And then, of course, you have amniotic membrane transplantation. So really the approach to a double pterygium, I mean, it's like I said, the area what you want to cut is really not necessarily up to the semilunar fold. We are not really looking at removing the entire pterygium tissue here like what has been described in a perfect technique, but really just removing a sufficient tissue so that you can achieve a good cosmesis, at the same time cover that bare area with a split conjunctival autograft. Now this step is very, very important, possibly already covered in earlier steps, earlier talks, wherein you need to create a smooth surface. Now creating a smooth surface is essential in ensuring that epithelialization takes place well and there are no tags of remnant tissue. Needless to say, dissecting all the tenon from underlying and getting just a simple thin conjunctival autograft is very, very important. We're trying to take it as large as possible, almost from both sides of the dissected area, and then we can then vertically split it. And this is a preferred choice for me. Now, it's not necessary that you actually cover it in the entire width as much as in the height. That is, the vertically you need to cover, because that is where from either one side